or 5 sentences for each one. And what I want you to do is, piece of pencil and paper, I want you to look at the presentation and write down things that concern you in the presentation, either to contraindicate your treatment entirely or to contraindicate manipulation in particular for the patient's painful problem. Does that make sense? So they're numbered 1 to 5. Just write the number down and then we'll discuss hows and whys of this. Okay. What I want to do is when you've got them written down, I'll call on different people. You give me the number and then you can explain your thinking. And then at the end of it, we'll see if we can come to some sort of consensus. Does that make sense? Okay, so here's the first one. It's a 43-year-old man complaining of pain in the right shoulder and mid-thoracic spine. There's no topographical connection between the two, so you haven't got pain running between them. The pain is an ache and comes on with lifting moderate weights and running for more than 2 miles. He has no history of similar pain and he has no significant medical history. Now, what I don't want is, it don't feel right, it makes me uncomfortable, all right? We're looking for specific reasons why those sentences, if they do, make you feel that you shouldn't be treating this patient, certainly not with manipulation. Is that okay? So it's all contained in each sentence, but when they all come together, they increase the probability of your decision whether to go ahead and treat them or not. But each one is self-contained, I think. All right, so just list the numbers. I'll leave this up. I'll call on some of you, okay? It'll be quick and almost painless. So there's not a lot of writing involved, just the numbers.
Oh. Yeah. Ah! Okay. Oh.
I mute Jerry again.
Jerry,
No.
You can't have any help, all right? All right, have you got them done? All right, Jerry, your face is on there. What numbers did you put? Jerry, are you still there?
Vote no.
All right, Nicole, you're next up. Nicole, you there?
Jen's there.
Yeah, Jen gets called on quite a bit. All right, Jen, what have you got?
Jenna. I just popped in. This is Jennifer. Are you asking for the level of the spine?
No, I'm not. I'm
No.
asking from these statements, each one is in its own right significant, all right? So the answer is wrapped up in each one, but when they're all added together, they will help you make a decision whether this patient should be treated by you or not, and whether you should use biomechanical treatments, particularly manipulation or not. All right, so there's 5 clues here, 5 statements, 5 sentences. Pick out the ones that make you concerned about this particular patient.
2 and 3.
2 and 3, okay. All right, tell me about 2 first, would you?
Complaining of pain in the right shoulder and mid-thoracic pain. I mean, it could be something cardiac, it could be something going on maybe in the lungs.
Okay,
Um,
all right, so you think this could be visceral. All right, now, you also said 3, so where are you with 3?
I was thinking a cardiac, but I also think maybe biomechanical.
Yeah, all right, look at the sentence. The pain is an ache comes on with lifting moderate weights and running more than 2 miles. We're going to assume this is both pains again. So lifting weights and running more than 2 miles bring on both the shoulder pain and the thoracic pain. What do you think of that?
Well, I think it could be cardiovascular, but then I'm also thinking it could be I don't know. I was thinking cardiovascular.
Okay, because if you're thinking biomechanical, why would running give you a shoulder problem like that and coming on at the same time as the thoracic pain?
Maybe something going on in the TL junction and then back
Now,
up into no.
that's
Okay.
not going to give you shoulder pain as well, is it? If you look at this, these 2 symptoms are shoulder pain and mid-thoracic pain. Yeah.
Yep.
There's no link between them. And there's also no referral between the two anyway. Even if the pain did run in from the mid-thoracic over to the shoulder, there's no neurophysiological or neurological link between the two. So typically, I think a physician would look at the heart first before he started worrying about anything else. Now, granted, that's their training, but in this case, their training is spot on. So that's basically screaming at you. This isn't typical musculoskeletal. Then you've got the onset of pain with lifting weights and running. Again, neither of these two are really going to bother the shoulder and the chest together. The other two don't matter. No history of similar. Well, no history of similar pain also argues against the biomechanical dysfunction. Yeah.
Okay.
So you're good.
Yeah.
You got it right, but try to think like past all of you, pass the sentences around, pass what the patient's saying to you in more detail. But those 2 things should make you sit back and go, hello, what's going on here? Yeah?
Yeah.
Good, you're off the hook.
Woohoo!
Okay, 16-year-old competitive runner. She's a sprinter, complaining of pain in the right forefoot, gradual onset over 3 weeks, and now she's unable to run. There's some bruising and puffiness in the middle transverse arch, the middle of the transverse arch. Okay, so all of you, write down the numbers that concern you. Okay. Emily, you're staring me right in the face. What have you got?
4,
4,
3,
3,
due to the mechanism isn't really there for maybe a biomechanical because it's just gradual onset. Like there's not a change. It's not saying there's a change.
good.
Activity.
It also implies that it's getting worse, doesn't it?
Yeah.
If she's unable to run now.
Mhm.
So it's clearly got worse.
Yeah.
4,
Again, I don't know about like the mechanism for the bruising and the
there's no trauma. Yeah, so yeah, so you've got bruising and puffiness in the middle of the transverse arch. She's also 16. All right.
Yeah.
So she shouldn't, well, she's a sprinter, a competitive sprinter, so she's actually put herself in a position where she can have adult injuries like biomechanical dysfunctions. But this doesn't seem to be it. So what do you think the diagnosis is?
I'm thinking stress fracture.
Yeah, that's what I would think as well. Good. You have to wonder whether she's got osteoporosis, if she's an anorexic or bulimic, going along with the amount of exercise she's doing. Yeah.
Mhm.
So she could have bone fragility. Now,
Right.
if you think about this in terms of differential diagnosis now, let's have a look. That was good. That was fine, Emily.
Okay.
Frank, can you give me 2 other differential diagnoses for this? Frank, are you there? Okay, Julius.
Yeah, so maybe a tendinopathy, because she's a sprinter, so she's using a lot of power more than like a distance runner.
Okay. Another one.
Mm,
Say no if you can't think of it.
yeah, no, that's all I got.
Okay, anybody else got anything? Tinteo. Are you there, Tinteo? Maggie. Does anybody want to chime in and give me another differential diagnosis for this? Other than a fracture.
Don't
Emma,
don't totally rip me apart, but could you say an onset of like plantar fasciosis? I mean, like history of that's returning. It's midfoot. I'm thinking poor footwear.
it's actually not midfoot, it's a transverse arch, which is sort more forefoot, isn't it?
Yeah, yeah.
Could be like
I
a
never
muscle
rip anybody to pieces on this. You got that impression, but I never do.
metatarsalgia.
Okay, yeah, we can worry about that diagnosis later on. Absolutely, metatarsalgia, which would include almost everything there, wouldn't it? Bursitis, stress fractures, and so on. So the differentials come from that. But if you look at the differentials here, clearly stress fractures as it over everything else, doesn't it? Because of the bruising. If it's just puffy, it might be bursitis. It may just be edema in the foot from a tendinopathy or that type of thing. But the bruising said there's something bleeding there. Yeah. You good, everybody? Okay, here's your next one. 35-year-old man complained of pain left back and upper buttock for 2 weeks with no change. He's had one previous episode of the same about 4 months ago, and it lasted about a week. He has pain on running that increases with the run and aches for about 30 minutes afterwards. Range of motion is extension left side flexion, left rotation, limited to about 25% and painful. Left extension quadrant gives more pain than the cardinal movements do. Okay, I think there's another one there, isn't there? P over L5 is moderately positive and the SI sulcus is tender. So anything concerns you there, write the number down. Right, Kelsey, your work. What have you got there?
I'm looking at like number 5 and number 6,
Right.
in conjunction with his age too.
Why?
Just the fact that extension and flexion and
No, not
rotation.
flexion. No, look at it again. It's extension, left side flexion, left.
Oh, like
rotation.
lateral. Okay.
Yeah.
Okay. So kind of looking through that more with the SI and yeah, I guess just with his age, I'd want to kind of rule out something like ankylosing spondylitis or something going on in there too, just with his age. But those are the ones that kind of jump out to me to rule out.
Is there anything unusual there that would worry? Not the general idea that ankylosing may be in a 35-year-old man, and you need to rule that out. But anything specific there that gives you concern about what the diagnosis? If the diagnosis turns out to be ankylosing spondylitis, would that make you surprised? Versus the diagnosis turned out to be segmental dysfunction. Which one would surprise you? The one that would surprise me would be ankylosing spondylitis.
Yeah.
Okay, so do you see anything on there that's of concern? It's unusual.
I'm not sure.
Because there isn't anything.
Yeah.
You've got to have
Okay.
conviction about this, yeah? There isn't anything on there that's not typical low back pain.
Yeah.
Nothing at all.
Okay.
So that's why you're hesitating, because you think I've put something in all of them. I haven't.
Okay.
These are patients.
Yeah.
Let's say that you were worried about ankylosing. How would you make sure, well, in your clinic, how would you make yourself comfortable that he doesn't have ankylosing then?
I think that I would check a little bit more from the subjective and just kind of, see if there is any onset without some of that movement, kind of basic for there, or any kind of like underlying, inflammatory disorders with it too.
How do you
But-
find that out?
Again, more kind of subjective history from him before kind of referring out to kind of check it.
Sure, but exactly, specifically, what would you be looking for? You're obviously interested in systemic inflammation. The pain's got to start somewhere, and it's often in the SI joint that it starts. If this joint was inflamed, what would it look like?
Well, you've already kind of pointed out like that the SI area is tender through there. So that's already kind of a check it thing for me. If it's kind of newer and it's just that initial onset, I'm not really expecting a ton of hypomobility as much as the, just kind of pain with some of that movement. So I guess
Well, the range of motion loss, if that's what we're talking about, is caused by pain. It's
Okay.
never caused by the joint locking up or not moving. There's too many joints to take over from it, so you get a lot of compensation. And we see this all the time in classes. Patient has your partner has full range of motion, but you find 2 or 3 subluxations in there. It's because all the other joints are compensating for it or overcompensating for it. So it's the pain that stops the movement, really. It's inflamed, so you're looking for a lot of post-activity aching, aren't you?
Yep.
Yeah, but you can also do things like, what's the test where you measure the spine inflection and extension? Tubers test, isn't it? Cobas. And you can look at rib expansion. You can measure rib expansion as well. Okay, but try to be specific in the way you're thinking about this. Instead of, I don't feel comfortable, or I would do tests to find out if it was inflamed or not. Think about what specific tests you would do. Okay? But that's why you're hesitating, because there's nothing in, that's almost a good description of either a lumbar dysfunction or a sacroiliac dysfunction, or both. You've got positive fortings, moderate PA, basically an articular restriction of range. It's pretty typical, isn't it? That's why he was having trouble with it, because I'm rat. Okay, this one, we've got a 40-year-old woman complaining of central and bilateral low back aching, pain on prolonged standing, which is relieved by sitting, occasional pain at night, which disturbs her sleep. And when that happens, she finds herself lying on her back. That's what wakes her up. There's no similar history and no medical history of significance. Okay. Okay. Shannon, do you want to have a go at this one? Don't say no.
Sure.
What's your numbers?
Okay, I was thinking number 2.
Yeah.
I mean, I think kind of like all of them together paints a picture, but number 2, because you're having bilateral symptoms,
Okay.
which could be, it could be just, I would like want to make sure that she's not having like bilateral symptoms down her legs.
We're saying this is just a symptom there. This is bilateral low back aching. If you look at this,
Okay.
this is central and bilateral central pain. So she's got central pain and the pain is spreading out across her low back. Okay, that's what the
Okay.
pain is. Is there anything in those two things, central and bilateral pain, that really gives you pause for concern?
No, I mean, it could just be that could be a biomechanical dysfunction.
Okay,
I
now,
guess.
how many biomechanical dysfunctions do you see bilaterally like this?
Right. Okay. Okay.
They're
No,
unusual, aren't they?
normally it's unilateral. Yeah.
Yeah, they're also unilateral. You don't get them in the center of the spine, do you?
No.
No. So if it's in the center of the spine, we're looking at something central.
Okay.
The vertebra, the disc, whatever. But it's not a facet joint because that's unilateral. So it's something in the center of this. And then it's spreading out both ways. So you're quite right, that's of concern. Now, let's take the next one there because you had 3. Given that, pain on prolonged standing, which is relieved by sitting. Is that a problem for you?
I think the positive to this is that it changes. It's not like a constant pain, but just 3 paired with 4, we have like pain with more extension based
Okay,
things.
sure, that's what it's telling you, but are you concerned about what it's telling you?
With number 3 by itself.
Yeah,
Mm. Not necessarily.
okay. Yeah, that's telling you, that's giving you information, but I don't think at the moment that's a major concern.
Right.
Occasional pain at night, which disturbs sleep and finds her light when she's laying on her back. Now, how badly concerned are you about night pain in general?
Yeah. Night pain is going to be more significant of a bigger diagnosis, I would say, because
Okay.
they're at rest.
Now, look at the rest of it. She gets the pain when she lays on her back. So are you thinking this is a tumor or an infection?
I guess I would have to ask more questions to follow that up.
No, just,
Like, is
no,
it-
I want you to pass this particular sentence.
Okay,
Why would
Well,
it
again-
occur only laying on the back if it's a tumor or an infection?
she's putting pressure on it,
Is she,
laying on her back.
how is she doing that? Like, what position is the spine going to go into? Assuming she's on a non-saggy bed.
More into like an extension.
Yeah, well, you've already got that, haven't you now? Because you've got pain on prolonged standing by, which is relieved by sitting. You've got the same thing going on here. It's telling you the same thing.
Right, so
Yeah.
we have pain with extension.
Yeah. So what central condition is going to give you pain on? Actually, it's not even standing. It's not even extension. It is lordosis. What central condition will give you a pain on lordosing?
Like a stenosis or like a
Okay. Yeah, good.
spondylolisthesis.
So stenosis. Now, does she have degenerative stenosis?
No, she's 40,
Yeah. So what could this be?
like a spondylolisthesis.
Exactly. Yeah. Good. Yeah. Okay. All you got to do
And
now is
then-
put this together for yourself. You've got all the information. I'm having to prompt you a bit here, but all you have to do now, and I know this is right off the bat, all you have to do is put this together yourself. But you're right. That's probably what it is. She's the right age for degenerative spondylolisthesis. Everything else fits here. Now, if this was pain on flexion and extension, or if you prefer lordosis and kyphosis, but flexion and extension, what could this be? Not you. You've done good there. So let's see who we got here. Anna, are you back?
I am. What's up?
Okay, we've come to the conclusion it's a spondylolisthesis. But if the pain was just was in flexion and extension, what could this be?
If it's inflection and extension, it could be a central, well, you already know you're getting a guillotine effect.
Sorry,
With
say again?
wouldn't you be getting a guillotine effect
Of what? What are we guillotining?
of the spinal cord and its surrounding dura?
Not really, because this is well, actually though, if it's extension and flexion, so she gets pain on both, going both ways.
Mhm.
So I'm not sure anything's being cut off here. Certainly
Okay.
not flexion.
So if it's flexion and extension, it wouldn't be the facet joints.
No.
So we're thinking it's the having a brain fart here.
Okay, well, a disc.
Yes, that word. Yes, that was
Somebody
my
wrote-
first thought.
All right, there is this, a contained or an uncontained disc. Given her pain patterns.
Given her pain pattern, because it's not constant, I would say contained.
Well, and non-contained, but non-contained disc herniations aren't constant neither.
So what I mean, I
Um,
guess not so much not constant, but because she's able to relieve it and it's comes on with consistent
They both
triggers.
do though. The fact is she's got no leg pain. So the chance of this being an uncontained herniation and not compressing the dura is not very high. This is probably a contained herniation. Now, somebody else, what's the problem with that? with this, with the whole presentation for this being a contained disc herniation. If it was both flexion and extension.
No, she's trying to decide if I need to reject it or not.
Her age, she's 40. She's about 10 years too old for it. I mean, I know things happen, but it's unlikely. All right. Any questions on this or the previous ones come to that? All right, next, 34-year-old man complaining of moderate to severe right low back and upper buttock pain. Yeah, what the hell. He has pain on walking and twisting the right. One previous episode of similar but less intense pain 2 months ago that lasted 2 weeks. Anything there that concerns you, put it down. I'm going to give you this one. This is easier than the previous one, isn't it? With low back pain. This is almost the essential illness script for lumbosacral sacroiliac joint problems. Yeah? That was one I was putting in, but never quite finished it, so I apologize for that one. All right, 37-year-old female, rear and front end MVA. She had direct trauma of her forehead to the steering wheel. She's complaining of pain in the posterior occiput and forehead. The initial pain in the forehead, the initial pain was in the forehead. The x-rays were negative. She had delayed pain in the occiput. 2 days later, she felt the occiput. Okay, so put the numbers down of what concerns you here. Okay, let's have a look. Maggie, are you back? No. Laura, you're up.
Numbers 2, 3, and 5 concern me.
2, 3, and 5. Okay. Why number 2?
Just because it's a traumatic event.
Yeah,
So
very
there
traumatic
was-
event. Yeah, which is why she probably had the x-rays. Yeah. That's going to breach both the Nexus rules and the Canadian C-spine rules. Okay, the x-rays are negative though. So, but you're still correct to be worried about that. 2, 3, why 3?
Just the pain in both the front of her head and the back of her head. I don't like both of them. I think it's kind of vague almost.
Okay, do you expect the forehead pain given she banged her head on the steering wheel?
Yes, it's more
Yeah.
the back head pain than how that
Okay,
came.
now look at the occipital pain. Think about it. Is that referred from the forehead?
No, not
I wouldn't have thought so.
if it
I
can,
mean-
or you can or can't.
Yeah, I mean, if it was referred from the forehead, which would be very unusual, things go the other way, don't they? But if it was referred from the forehead to the occiput, you'd expect a connection between the two, wouldn't you? Pain connection. Topographically, they should be linked. The occipital pain was delayed to, you had 5, delayed occipital pain. Why are you worried about that?
Just that it took 2 days to kind of be delayed. I feel like that's a longer time. I feel
Okay,
like delayed like next morning or
Yeah, I would tend to agree with you. So the question is, really here, where's the occipital pain coming from? And if you look closely at this question, actually, not if you don't look, you can look at it superficially, but where is a mention of a neck pain?
There isn't any.
No. So where's the occipital pain coming from?
I don't know.
Give it a bit of thought.
I mean, I think more maybe like a concussion type thing, but
It could do, but this is very local. Concussion tends not to be local like this. What if I said she had trouble laying on her back and that's when her occiput hurt her more?
a fracture in the back of the head then?
There's no direct trauma.
Okay, so maybe like an instability then?
Where? Neck?
Yeah,
Yeah,
either,
she's got no neck pain.
I guess if there were if she had upper cervical that was referring, but
Okay, not only was laying on her back hurting her, but this pain is gradually getting worse.
if it was gradually getting worse, I would say more of like a brain bleed then.
Yeah, that's it, exactly. The question I've got then is, why didn't a bleed occur to you? Now, I'm only asking that because you need to think about it. You all need to think about it. Why wasn't a bleed, why didn't it occur to you?
I guess because there's no mention of a headache, so I didn't really
Yes,
think.
she's got,
bleed.
the occiput is her head. It's part of her head.
Yeah, I guess.
Ah, so it's basically, it's bias. No, the occiput's part of her head. You're linking it with the neck because mostly we see occipital pain as referral from the neck. But nonetheless, anatomically, the occiput is the head. You can have a bleed in the occipital lobe. Yeah.
Yeah.
Now, what makes that unlikely? Now I've said that. What makes all this unlikely? This is an occipital bleed. Actually, I'll give you a break. Dylan, what makes it unlikely? Are you there? Apparently not. Tanner. Are you there, mate?
Which one? I'll field it.
Burger. I think you're the only Tanner I've got on today.
I'm not logged on my computer because I was driving for the first part of it. This is Timmerman,
Okay.
but I can field it if you want.
All right, no, don't worry. Who? No, don't do that if you're driving, you can't see the screen. Isaac. Anybody, actually. What makes this unlikely to be a bleed? In the absence of anybody else answering, Isaac.
Because it's localized to the occiput and it's not progressively.
Oh no, it was progressive. I gave that to I'm sorry, who was I just talking to? No, it is progressive. As Maggie was.
It is progressive.
Yeah. Now we've established from that bit what we was talking about that this is a bleed into the occipital region. But it's not very, very likely. Why not? From all that presentation.
I don't know.
Her age. Slow bleeds like this are subdural bleeds and they occur mostly in older people at high velocities And this accident does count as that because of the double impact. But it's usually over 60s, over 65 sometimes. He's too young for it, really. Now, that's been on various videos. Do you know why older people rather than younger people have bleeds? Anybody? I know it's been presented to you.
Are their blood vessels less elastic?
Well, the reason is that as you age, your brain shrinks and the veins, and it's a venous bleed, the veins between the dura and the cranium get stretched. So any shear or torque force going through them tends to tear them. It's a slow bleed because it's venous blood. So this can take up to about 3 weeks before it really makes itself felt. So this is something post-trauma with an older, particularly with an older person, you need to be aware of. This needs to go out of your clinic. Progressive headaches are never good. And post-trauma with gravity dependence, when you're laying down and the bleeding point is at the bottom of the head, the pressure increases. So if I've got a bleed in my left temporal area and I lay on the left side, that will increase the pressure on the bleed and make it more painful. These are gravity dependent pains. Okay. Excuse me. Okay, we've got a 58-year-old man complaining of burning pain and paresthesia around the right side of his chest from the spine to the sternum at about T5 level, all right, just on the right side. Onset was insidious 3 weeks ago and there's no progression or improvement. Pain on trunk rotation, left more than right. It's an electric type of pain, and reaching overhead to put on a shirt or lifting his arms in a shower produces the same pain as well. Passive range of motion, both rotations are full range but painful for the last half of the movement. No pain on overpressure. And both shoulder elevations are painful to the chest. Okay, so again, write out what concerns you, and I'll pick on some poor sod. Okay, Jenna, you've annoyed me over the last few months. Let's use you.
Always.
Which ones bother you?
2, 4,
2,
and 6.
2, 4,
Yep.
and 6. Okay. All right. Why 2?
Burning pain and paresthesia that goes around into the chest to the sternum.
Yeah. What about it? What gives you concern about it?
I don't like the fat that wrecks around into the front of the chest.
What
From
are you
T5
thinking?
level.
What are you thinking that might indicate as far as pathology is concerned?
Dingles.
Okay. Well, all right, leave that one, come back to it. Well, what it's telling you is this is neurological pain, isn't it?
Yep, exactly. Such as a or that electric type pain.
Yeah.
It says in 4.
Yeah, burning pain, actually.
Yep.
It's a burning pain, so it's consalgic plus paresthesia, that's neurological. The onset was, what have you got? 4. Pain on trunk rotation, left more than right, and it gave electric pain and reaching over to put on a shirt or lifting arms in the shower.
Yeah, I don't like that electric type pain, that lancinating pain.
Okay, so again, why not?
It's again neurologic
Okay,
pain.
yeah, good. Both rotating full range, but painful for the last half of the movement. No pain on overpressure.
Well, I didn't like 6 either. like going up
Oh,
to chest.
you didn't have 5 then, no 5. Okay,
Well, 5, it kind of rules out like the shoulder, almost like for me.
it sort of rules out the shoulder and the chest. If you're not getting pain on overpressure here, it's unlikely to be either the shoulders or the chest.
Right.
All right.
Yeah, so I don't really like the fact that she has pain with both shoulder elevations to chest, like
Okay.
that chest lock.
Okay, so that's fair enough.
Oh, Dave, you're up.
Oh, I'm sorry, Jen. What are the other 5 differentials this could be?
5? I have no idea.
I just thought that would easily eat up 10 minutes.
Oh yeah, totally.
Okay, what
I
are
said
your other?
jingle.
What are your? Yeah, why is it shingles? And it is.
Just that dermatomal pattern that it has.
What else in there kind of supports that?
Like the movement patterns, like the rotation.
Yeah, it wasn't provoked on movement.
Yep.
I think you also had in there somewhere either joint glides or the joint motion or moving the joint
Yeah.
didn't provoke it. So, he's giving you there is a lack of, basically articular findings. So you know that, okay, articularly, if he's moving the joint, it's not reproducing the pain.
Sorry
And
about that.
banding around the rib too. Jenna's just giving her 5 differentials.
Well,
I got you.
I told you she was a pain in the ass, didn't I? I'm sorry, my computer died on me for some reason, just turned itself off. Okay, so actually this was going to be my question. There was no rash. And given
Okay.
his age, shingles is a pretty fair bet. Okay.
Yeah, and the age.
But there was no rash.
Maybe they caught it early.
Yeah.
Well, no, because you got him in your clinic.
I don't know. I saw someone like 2 days ago that didn't have a rash and still had all this crap
It
going
does
on.
happen. It does happen, but it's not usual. It does happen. But if there's no rash, if it's shingles, you can phone the doctor and say, listen, this guy's got shingles. And you probably wouldn't see him anyway. If there's no rash, you can't say that. All you can say is, I have no idea what the hell it is, but it's neurological. It's not musculoskeletal. Get it out.
Yeah. Right, exactly. I was thinking the exact same thing. Goodbye.
Yeah, good. Good. Last one. By the way, nobody ever commented. Do you like my Roderick and Frederick? You're going to get more of this crap because I'm getting bored. All right, we've got a 40-year-old woman complaining of severe pain across the low back, 2 weeks duration, not progressing. On examination, flexion is much worse than extension, although extension is positive. And she tells you that when she puts her head forward, she gets sharp electric shock pain in the limbs. All right. So, what have we got left? Anybody want to volunteer for it? Alex.
All right, so let's go on the list here. So we have 2 severe pain in the low back across the whole low back, so it's bilateral.
That's what she's coming complaining of, yeah.
Yeah. Okay. So 2 weeks duration, not progressing. So flexion is much worse than extension. Neck flexion, produces sharp. So if it's neck and low back, do you think it's some kind of central stenosis?
No. She's
Okay.
40 years old.
Okay.
Which one of those concerns you most? Which one of those sentences?
I'd say 5.
Okay. I would tend to agree with you. So what's causing it?
Could be, let's see. Do we know like a mechanism of injury?
Nope,
Okay.
you've got it all there. Every one of those is self-contained.
Okay. So if neck flexion produces sharp pain, and maybe some kind of upper cervical instability.
No, not with this. This is a
Okay.
well-known phenomenon. Does anybody know what it is? And I'm sure you've all been taught it somewhere at school. Anybody?
What hermit sign?
Lermit sign, yeah. Who was that?
Ryan.
Yeah, that's exactly Lermit sign. The most common cause of it is multiple sclerosis. Well done, Ryan. You've all heard of it, haven't you? Somewhere or another, in the deep recesses of your memory, it jingles a bell, doesn't it? Doesn't matter what a back's doing at all. That piece of information stops you dead. Okay. But forgetting that bit, what's her problem? She can't flex, she can't extend. This one isn't something you come across very often. You're going to need a lot more information on this, which I haven't given you. You're going to need a lot more information from her before you even think about biomechanical, designated as a biomechanical dysfunction. It's very unlikely to be, because of the severity of the pain and the fact that it's all the way across the back. It means it's unlikely to be a biomechanical dysfunction. But that doesn't matter. The neck flexion trumps everything. Okay, she's got Lermit sign. It could be a myelopathy. Mostly it's MS, but it's certainly not within your remit to keep her in your clinic. Are we good? Now, what I want to know, if anybody wants to give me feedback, I'd really appreciate it, is how useful this exercise was.
I wish we could have done this a lot more.
Yes.
Well, I could give you this, well, maybe, but this has to come at the end. It really has to come at the end, simply because you haven't got the information to do this earlier on.
Like, it's nice to have like these one, especially when we've done like the illness scripts or whatever, having this really kind of makes everything kind of come together. So I really liked it.
Well, what I'll do is I'll give Dave the PDF to these slides. And if you like, I'll set you some more up that you can do on your own. You can send them to me. And what I'll do is, if I do that, I'll send you a bunch of them over within the next couple of 3 days. You get them done. And then I'll make a video of what I think the solution is. That work?
That would be great.
Okie doke. All right, well, I'm done, Dave.
That was good.
Thank you all.